Good morning. First of all, I would like to thank Professor Muhammad Omar Farouk for the invitation, and sorry I cannot be there in person. Today I'm going to answer a very important question. Is EVAR management undergoing paradigm shift? Before we start, we have to differentiate it between stable and regressed aneurysm sac. Why is that? Because we have a new evidence suggests there is a reason to differentiate it between both, because regressing sac are linked to the higher long-term survival than stable sac. This is a very nice VQI study. They review about 14,000 patients, and they found that sac regression is linked to the better long-term survival comparing with a stable or expanding sac. Another meta-analysis, they look at 17,000 patients, and they found that sac regression is linked to the better outcome regarding all-cause mortality, aneurysm-related mortality, aneurysm rupture, secondary interventions, endoleak, and aneurysm-related complications. But is there any clinical predictor for sac shrinkage after EVAR? This is a nice paper look at some anatomical predictors, and they found that the neck thrombus, AAA thrombus, number of hostile neck parameter, total AAA volume, AAA flow lumen volume, and aortic calcification could play a role in the AAA remodeling after EVAR, but unfortunately the evidence is not strong. Another paper, they look at some predictors. It's a retrospective single center study. They study about 174 patients, and they found that if you have a larger preoperative maximum AAA diameter, you have a higher chance that the sac will regress after EVAR, where if the patient is old and has a large preoperative infrarenal angulation, you have less chance that the sac will regress after EVAR. But the problem is that the multivariable logistic regression models was not corrected enough with all patients, only 2/3 of the patients. So this data is not sufficient to be implanted on the clinical practice. Is there any device-related factors going to impact the sac regression? They compared suprarenal versus infrarenal fixations, type of the EVAR graft material, and finally endo anchors. When they look at the suprarenal stent fixations during the EVARs, they found that you have a better chance of sac regression if you have used the suprarenal fixations, because it gives you a better seal and less chance of type 1 endoleak, because it separates fixation from the seal, unlike the infrarenal fixation where the seal dependent on the infrarenal pins penetrating the tissue, where the suprarenal fixation allows sealing to occur independently from the neck, which could be not healthy and depend on a healthy suprarenal aorta. Also, it reduces the main body migration risk and device movement. What about the type of the graft material? They found that multifilament polyester material provide a resistant against type 2 endoleak and durable hemostatic barrier and may play a role in the sac regression. This is an in vitro study. They compared two polyester graft with a 3-BTFE graft, and they found that polyester graft, if you use a polyester graft, you have higher chance of the sac regression compared with a BTFE, where if you use a BTFE, you have higher chance of the sac expanding at type 2 endoleak. But in clinical practice, does this apply? This is a new trial called an advanced trial. It's still ongoing. They're going to compare endograft, which is polyester material, with the excluder, which is BTFE, and to see if they impact the sac regression, and the endpoint is sac regression at 1 year. The result's not out, but hopefully we know that in the near future. What about the endo anchors? This is a study. They compared two groups with a standard aortic neck, and they found that at 2 years, if you use the endo anchors, your sac will regress almost double than the sac if you use a standard EVAR. It's 81% of sac regression at 2 years for ESAR, and only 50% sac regression for the standard EVAR. What about the hostile neck? This one, they look at the hostile neck. It's a propensity scored analysis, and they found the same when they follow up this patient, that if you use endo anchors, comparing with the standard EVAR, you have higher chance of the sac regression comparing with the standard EVAR. What about the anchor registry, where they look at the old patient with a hostile neck, where they use endo anchors, and they follow this patient for 5 years. And they found at 5 years, we have about 89% free from type 1 endoleak, 96% free from re-intervention for type 1 endoleak in the group who has endo anchors, 0% migration, and about 98% free from rupture, and the most important, 88% stable or regression sac. Then we have an engaged extended cohort where they follow up patient for 8 years, and they notice that if using endo anchors, the sac continue to regress up to the 8 years. Why is that important? Because they notice that if you sac regress, you'll have a better freedom from all-cause mortality up to the 8 years, better freedom from any secondary procedures. And also they notice that if the sac regression in the first year is a good indicator that the sac will continue to regress up to the 8 years. But if the sac stays stable in the first year, you have less chance that the sac will regress at 8 years. Only 50% will regress, but if regress in the first year, about 84% will continue to regress over 8 years. What about type 2 endoleak? They notice that if the patient has an isolated type 2 endoleak, you have a less chance that sac shrink, and most of these, the sac will stay stable or increase in size. So they conclude that if you have isolated type 2 endoleak, patient will experience a less AA sac regression and higher chance of the sac enlargement compared with the group who did not have type 2 endoleak. But why is that happening? All of us, we know that type 2 endoleak is a benign because there's a subset of the type 2 endoleak which indicate an occult type 1 endoleak, which we don't predict it, and we think that we are dealing only with type 2 endoleak. Why that happens? Because could be one of two. Could be patient has what we call dynamic intermittent endoleak, because during the cardiac cycle, the aorta pulsatile asymmetrically, which causes the intermittent separation between the aorta and the graft. So we have about 35% change in the aorta area between systolic and diastolic, and most changes happen on the anterior wall. So this can cause intermittent separation between the graft and the aorta, and cause intermittent type 1 endoleak, which is difficult to detect on regular CT angiogram. The other thing is what's called a postural dependent endoleak, where you cannot see the endoleak when patient supine position. Then you have to put patient in the prone position during CTA to detect this type of endoleak. So the question now comes is that should we treat all type 2 endoleak because it helps with the sac regressions? Does it really work to do that? I think, unfortunately, this paper looked at about 1,000 patients, and they found little evidence supporting the efficacy of secondary intervention for type 2 endoleak after EVAR, and the clinical course after intervention may not be different from conservative management. So until now, they don't want us to change our behavior. The way we look at type 2 endoleak, we still look at type 2 endoleak as a benign as far as the sac is stable or regress or shrink. But I think in the future, this I think will be changed. I think type 2 endoleak with a stable sac, I think will become unacceptable. I think we have to get to the sac regression with a type 2 endoleak, otherwise has to be treated. I think we don't have enough evidence for that, but I think the future will have more clinical data, and most probably we can change our way we look at the type 2 endoleak. What about sac embolization during EVAR? The study, they did that, and they found that if you do sac embolization, you have a better sac regression, less chance of type 2 endoleak. This leads some people to do what we call an active sac management by using a shape memory polymer. So during the procedure, you leave the catheter inside the aneurysm, then you do an EVAR, and at the end you fill up the sac with a polymer, and this will prevent type 2 endoleak and help the sac shrinkage. And you can see it here, and the material is fluorescent, so will not interfere with your angiogram. What is any clinical data for that? This is a new trial called AAA Shape Early Feasibility Study. It's a prospective multi-center up to the 30 patients They're looking at the efficacy of and safety of polymer during EVAR management. And so far, the results still early, but so far we have a significant SAC regression at 6 months in this group, with a mean change in the SAC diameter about 7 millimeter and mean change in the SAC volume about 25%. So in conclusion, there's a new evidence suggests there is a reason to differentiate it between a regression and stable aneurysms. Latest clinical evidence showed SAC regression is linked to the higher survival than stable AAA. Factors that impact SAC regression is depressurization, no endoleak, and hemostatic barrier, what could be the SAC material. Some type 2 endoleak may be intermittent type 1 endoleak that can lead to the treatment failure. And finally, endoanchor showed less chance of type 1A and type 2 endoleak and the better chance of the SAC regression up to the 8 years. So we go back to the main question of my lecture. Is EVAR undergoing paradigm shift? Yes. I think and shrink aneurysm SAC most likely become the goal of future in the for EVAR, as 1 year stable SAC are not always benign. So in the future, I think stable SAC will not be acceptable. We have to see SAC shrinkage as a sign of successful treatment. Type 2 endoleak may impact the SAC behavior and lead to the less SAC regression, while treatment of type 2 endoleak is not always successful. Again, this also may change in the futures, where we may change the way we look at type 2 endoleak, especially if the SAC does not regress. And finally, active SAC management may prove to be an important addition to standard EVAR, but adequate technique and the effectiveness still need to be defined. Thank you very much for listening.